My name is Kevin Simiu, and on behalf of the Aga Khan University, I wish to welcome all of you to the second webinar in our Connecting AKU webinar series. This series is very much intended for our wider AKU family, including our generous supporters, our former staff, volunteers, and especially our beloved alumni. Since we are physically distanced from each other, we hope that through this series, we can continue to engage with you and to share AKU's magnificent work, from insights into the global coronavirus pandemic to the various ways in which all of us can cope and manage to ensure that we are able to go back to leading our wholesome and productive lives. Today, we are very delighted to have with us Dr. Sean Deluca, CEO of the Aga Khan University Hospital in Nairobi, who is going to share with us how the hospital is preparing and managing the global pandemic. Sean Deluca has over 25 years of leadership experience in healthcare, during which time he has achieved major financial and operational successes in acute care hospitals and medical care centers, ranging in size from 120 to about 1,200 bed size. Prior to joining Aga Khan University Hospital in Nairobi, Dr. Deluca was the Chief Executive Officer for the Tulare Regional Medical Center in California in the USA. Today's session will run for 60 minutes. Dr. Deluca will be speaking for the first 20 to 25 minutes, and then he will take questions from the audience. To ask a question, please send an email to alumni.aku.edu, and we'll be able to answer those questions through Dr. Deluca. I will not waste any much time. I now wish to welcome Dr. Sean Deluca.
Thank you, Kevin. Good morning, good afternoon, good evening, and good night. I don't know where you guys are, but it is my pleasure to be with you. We will start with a brief presentation to provide you with some background, and I try to be brief and have more opportunity for questions and then answer. We have some technical difficulty here because my slides are not moving. Give me a second, please. Okay, I think we got it. Okay, thank you. Thank you. I think let's lay the foundation and talk about the situation. I'm sure majority of you are aware of it. The first case of the COVID-19 was announced in Wuhan in December 2019. And the first alert that we issued at Aga Khan University Hospital in Nairobi to our staff was on 27th of January 2020. And we started to do contingency planning at our hospital at the end of January. And by March, it became basically a pandemic. And we saw our first COVID patients in the hospital in March. And we were the first hospital in Kenya that admitted basically a COVID patients. For some of you that might not be familiar with the hospital, we are a 300-bed hospital. Our critical care capacity is 36 critical care beds. We are basically having 25 ventilators, but in case of emergency, we can increase the capacity on our critical care units up to 60 beds, okay? We started testing on 13 March 2020. We have finished 688 tests to date. 25 of them were positive and 663 of them were negative. We have admitted basically 58 COVID-19 related or suspected cases in the hospital. From them, 14, they became positive, and here is the distribution. We had 5 of them in ICU, and unfortunately, from the 5 that we had in ICU, 2 of them, because of a lot of comorbidity and high age, advanced age, above 68 and 70, did not have a good outcome. And then 7 of them, they have recovered and they have been discharged. If you look at from the 14, 12 of them, they have been basically recovered. I think our recovery rate is within the reasonable range. Now, how did we basically respond to this? Normally, when we look at our operations, we do it under 6 pillars. We look at the community, we look at quality compliance, we look at the people, we look at our finance, then we look at the service, and we look at our growth. On the community level, we looked at it basically our external community and internal community. And we started collaborating with the government. In many areas, we are actually helping the Ministry of Health. And recently, I received a letter from them to nominate some of our colleagues in a various, basically, working group or technical committees of Ministry of Health for the infectious disease, disaster preparedness. Then we needed to also talk to our community. We have had the presentation for different AKDN organization with the Jamaat and also international organization. We were receiving a lot of requests from different diplomatic corps and also from UN. Therefore, we did have a meeting that we invited all the chief medical officers of the different embassies and the UN, and we give them a presentation about our preparedness. We have had also a lot of sessions with the insurance companies to inform them and also to prepare their members. One of the first thing that we did in March, we set up a 24 hours, 7 days hotline. And this hotline is basically manned by trained nurses. And they have been all scripted. And people, they call them. And that helped us basically to avoid 2,000 people to come to ED for no reason. And then from the strategy point of view, trying to control cross-contamination, I think that was an effective way of removing anxiety, answer the questions. And we are right now looking at opportunity to launch a COVID-19 application for managing some of these patients from home, that they can put on a daily basis their symptoms, and then there is artificial intelligence that tells us how we need to manage them if they need to come to the hospital. Internal. I think one of the biggest issue was during this time that everybody is anxious, we create a calmness for our colleague. We have 3,000 employees here. If they are not mentally prepared and we cannot give them assurance this is a safe place for them to work, then it will impact our efficiency and our productivity. The first thing that we did, basically a lot of interview with the media, with the hospital leadership, with the infectious disease. We had even some of the colleagues talking to BBC and different, local and international media. One of the things that we did when we basically put our contingency plan, we needed to find out if there is a surge of the patients, how are we going to deal with it? We do have a disaster management plan, which is HICS, is basically the same disaster management plan that is being used in the state of California. We use the same nursing staffing ratio like state of California. Then we took our disaster management plan and we developed something that was very specific regarding COVID. And here, as you can see, these are some of the samples for the public messaging. that they are basically on our websites, and we have put it in a newspaper, and you can go to the link, and all this information and library is available for public and also for our employees. Now, when we look at the quality, development of the contingency plan to define processes and accountabilities and timelines. For example, for every specific department, there is a clinical pathway how to manage a COVID patients. If it's surgery, if it's maternity, if it's internal medicine, family medicine, rehab, for each one, we do have a clinical pathway that is very clear what you need to do and what precautions you need to do. We have had, we increased our inventory for PPEs. We have spent close to 500 million shillings, close to $5 million to increase our inventory. And the guiding principle has been we need at least 6 months of inventory on hand, but we have been also very creative. What else can we do to make sure the environment is safe for our employees? As you saw, the number of the patients that we have tested or the number of patients that we have admitted here, I'm very pleased to say, so far, we have not had any community transmission within the hospital. And even when we do have the slightest doubt that maybe somebody has come in contact with the patients and the patients, they did not follow the proper procedures, we do quarantine them for 14 days and we monitor them and we do the test. When everything is negative, we will ask them to come back. We talked about basically clinical development of the protocol for the COVID-19 in 10 departments. But one of the issues based on the knowledge that we are gaining from the developed world and from US and from Europe and other countries is when there is a lack of, how should I say, resources. How many ventilators can we buy? Even if you buy a lot of ventilators, we need still a competent staff to operate it. And one of my discussions with my colleague was there are a lot of passengers. I can go and buy a plane, but if I don't have a pilot to fly it, what difference does it make? This is the same situation. Then we decided that we need to basically develop some ethical guidelines in consultation with our ethics committee, Ministry of Health, and some of the religious leaders from different religions. If we get to a point that we need to rationalize the use of our critical supplies, how do we do that? If I have 3 patients and one of them needs a ventilator, who is going to go on the ventilator? Who is going to go on the life support equipment? I think these are the things that you need to get ready for it. We have basically trained our nurses and clinical team for all the precautionary measures that they need to take. For example, we have identified some people as the champions. We do have a dedicated housekeeper team. There are 35 of them that they have received the specific training how to do the disinfections, and around the clock, they are cleaning the hospital. This is, for example, the COVID-19 contingency plan. I don't want you guys to read everything. I'm just telling you, this is a 53 pages that talks about different levels. It talks about different patients. It has a flow chart. If you have a COVID patient suspect, patients that they are basically positive and they are stable, patients that they have a comorbidity, patients that they need supportive care, and the patients that they need basically critical care. As you can see here is what we look at it. We do have a COVID task force that meets every day from 10 to 11. And we have been doing this one religiously for the past 3 months, but now we think we have a pretty good handle. We meet twice a week, Tuesday and Thursday. As you can see, we look at, for example, on the inventory on a daily basis, and how many gloves we have here, how many gowns we have. And you see, as per COVID consumption scenario, it means we have seen a surge in our consumption. For gloves, non-sterile, we have 7 months of supply on hands. For the gloves that they are sterile, we have 16 months. The areas that we are less than 6 months, we are focusing on that one, okay? For example, for the face masks, 3-ply face masks, we are ordering that one from US, and face shield. And then one of the areas that we did have a challenge was actually hand sanitizers. And in order to increase basically our supplies and make sure the quality is there, we had a contract with the brewery because they are still here right now. Nobody is working. We asked them to manufacture some alcohol for us. And our pharmacy now is providing hand sanitizer for the hospital. And we are hoping that by the end of this month, we will be getting to a 6-month supply, and we know the quality is right. But in order to also understand who can do what, when we trained a specific group of the people in each department regarding COVID, we have identified them with a different stickers, which is on their name badge, which says C19 champion. Those are the people that you are resourced in the department. If the nurses, housekeepers, somebody has a questions, they go to them. And also they act like a navigator. They will observe people how they put their PPE on and how they take their PPE on to make sure there is no cross-contamination. And we spend a lot of money buying equipment specifically designated for COVID-19. For example, we bought additional portable X-ray. We bought additional, portable ultrasound. And those equipment, they have been also identified with the sticker that it says C19 equipment. And there is a very specific process. How do you disinfect this equipment? We ordered a lot of, as you can say, it's face shield. You might say, okay, everybody has a face shield. No, we have ordered a lot of them, and they are color coded. And we have developed sets. We have 6 sets. For example, set 1 and set 2 is for ED. Set 3 and set 4 is for surgery. Set 5 and 6 are for ICU. And then in the morning, when people, they come, there is a box that comes with all the face shield for a day shift. After the day shift is done, they will put it in a red box and it goes to the central supply. It gets disinfected and gets ready for the next shift that comes in the morning. And the reason we are doing that, we want to make sure there is no cross-contamination. And we have ordered also some face shield for the transportation of the patients that they are COVID positive or suspect, to make sure that we are taking double precaution and they have a different color code and distribute that evenly throughout the hospital. Like this. What is going on? Okay. Now, in order to put people at ease, we do have a town hall session. That happens, with the president and the leadership of the university. We do have a daily update that we send after the task force meeting is over to the employees. Then we do have every Friday a forum for 1 hour with the employees that they can ask questions to understand what we are doing. And I send every Friday a memo to the employees about what we have done, what precaution do we have taken, and where the basically hospital is moving. Staff safety, it is the highest priority. We try to balance between our consumable, for example, for the mask that we have, and at the same time, protect the employees when they are not in a hospital. N95 mask that you could buy at $1 is being sold right now out of the hospital for $20. And one of the issues is how do we basically control our inventory that's not walk away from the hospital, and how do we extend the life of the inventory? We have been able actually to experiment, and we realized we can re-sterilize our N95 mask maximum to 4 times if we use basically plasma sterilization. We have written an instruction for it. We are sharing it with our sister institution, our infectious disease control department that is run by Professor Adams from also University of Arizona has looked at it. It has been approved. But we said we need to do also something for employees when they are out of the hospital that they do not take these PPEs. We ordered 9,000 masks, cloth masks for the employees. And they have one to wear, one to wash, and keep one for emergency. We ordered 3,000 thermometers for each employees and their families to be able to measure the temperature. And we have also ordered 3,000 small hand sanitizers that the employees, they can basically hang it from their name badge or from their belt, that at any given time when they are going through the hospital, they touch the door handles or the doors, they should be able to basically sanitize their hands. And we have also identified a location for the employees that they might be exposed that has 30 beds or 30 rooms. In case the push comes to shove, we can isolate them to make sure they do not go to their families and create cross-contamination. Also, at the same time, staff welfare is important, okay? We have implemented telecommuting for people to work from home. We have arranged for the voluntary leave arrangement. We have looked at to accommodate the staff for maximum 800 staff. That is a core number that we need to run a hospital. Around the hospital, we have already identified everything. And one of the commitments that we made to our colleague is, God forbid, if anybody that is providing care for a patient, it becomes COVID positive, the university will assume the full responsibility for the treatment, and we cover them 100%. And the deductible that the employees, they had to pay as a part of their health insurance is going to be waived. And then the other issue is a psychological support program. We do understand that during this time, people are afraid. There is a lot of uncertainty. We do have a hotline that the employees, they can call in case they need to talk to somebody. We have developed basically a survey and a questionnaire that these employees, they can respond to it. And then it tells them if they are stressed out or they are not stressed out. There is a group session that our psychologists basically talk to employees. And we have created different venue for them to be able to, to be engaged in a discussion, and hopefully we can reduce their anxiety. Because if the workforce is anxious, the probability of making a mistake will be higher. And then it's going to have undesirable consequences for everybody. As you can see, we have developed a lot of guidelines for how do you use a personal protective equipment, because each area is different. Sometimes when you explain for people, it's difficult to remember, or you don't want people to read basically a instruction. In the visual format is very easy. As you can see, for example, for the direct healthcare worker, for basically staff in the laboratory, for general population, administrative staff, and these posters have been posted around the hospital in order for people in a very easy manner, they can see and what they have to do. Now, our services. We need to continue. We can just shut down the entire hospital and say, do you know what? There is COVID. But there are patients that suffer from chronic disease, patients that they need to have elective surgeries, people that they have heart problem. How do you create a stable situation when there is so much unknown? We started basically to work with the government, and today I had some discussion with Ministry of Health, how we're going to open the hospital. We will be offering a free COVID tests for any patients that they want to be admitted here, or any patients that comes from the elective surgery. But we need approval from the Ministry of Health, and they agreed with our approach. We believe if we do that, then we know upfront if the patient is positive or is negative. If it's negative, it's business as usual. If they are positive, then we take proper precaution. Okay? And now, we realized also if there is a surge, we need to be prepared for it. And we worked with the different embassies, and we decided to set up a field hospital, something between 80 to 120 additional bed. We did our calculation, maintaining the same nursing staffing ratio like the state of California. We realized we can do quality patient care for maximum 400 patients. Anything above and beyond that, we will make it basically difficult. We are looking at getting one ECMO machine and maybe a few additional ventilators. We modified our ventilators to basically accommodate 2 patients. I know this is a very sensitive subject. There are differences of opinion on it, but when you talk about emergency, you need to become creative, okay? We have 20,000 tests available here. We have even helped the government by sending them sometimes supplies. We are working with American manufacturing company for basically to get some additional equipment that we have that we can increase our testing capacity from 60 to 100 tests per day. And we are working with other embassies and getting support from them. What are we doing for HR? We realize if there is a surge, we need to have physicians. Therefore, we have sat down as a part of our COVID-19 contingency plan. And the discussion was, how are we going to deploy physicians, for example, that from anesthesiologists, OBGYN physician, radiologists, and pathologists to come and help internal medicine, family medicine, because they are the 2 departments that they will be under pressure to take care of these patients. We have developed a clinical pathway, and there is a team-based. For example, for the people that they are suspect and stable, we might be able to use other physicians, but those physicians are going to be working with the internal medicine or a family medicine as a lead and supported by infectious disease expert in order to be able to manage this surge that we might experience. And then the other contingency is to look at if the push comes to shove, we reduce the activities in our outreach clinics. We have 49 of them, and deploy the doctors and nurses to the main hospital. We have 96 doctors and 96 nurses that will give us just a little bit more flexibility. We have been working with US Embassy, and we have developed temporary privileges for some of the American doctors that they are in Kenya, and they are all board certified in US, and they do have a license to practice in Kenya in case we need some help, that we can ask them here to come and help us. What you see, the picture is the picture of the field hospital. We set it up ourselves. Everything that you see here, it has been actually designed and developed by our engineering team. And this is the first phase that gives us 40 hospitals and 40 beds. And the second phase is going to be additional 60 beds that we are working on it. We have received requests from the Ministry of Health and also from the Society of the Kenyan Architect to come and look at our field hospital and see what they have, how do we have set it up that they can use this one as a model for the other part of the country, because there is no other hospitals in the country that has actually set up a field hospital. And here is the way that you can see, we have basically, we're able to put 2 patients on a ventilator on the bed that is on my right side. As you can see, there is a box, and that box has been designed by our engineering department. When we are intubating the patient, that creates additional, basically, safety for the physicians to make sure that there is no, basically, cross-contamination. How do we want to basically get back to the business? Few creative ideas. You know what? I'm sure some of you that are in healthcare, for the past 6, 7, 8 years, we have heard about telemedicine, but nobody really was seriously looking at it. COVID-19 has forced people to come up with a different mode of delivering healthcare. I personally believe even when the COVID-19 is over, telemedicine is going to be one of the main modes of delivering healthcare. We have already launched our telemedicine here, and it is not as sophisticated as I want it to be. We are evaluating right now 2 different software, but preliminary result has been very favorable by the patients, especially for follow-up. We have developed a mobile lab. Basically, we do have a mobile phlebotomist that they come to your home, they take your blood, they bring it to the lab. And then we have also mobile pharmacy. We deliver your medication to your house free of charge. And then you can follow up with your physicians through the telemedicine, which is very convenient for people. And we are looking also at the possibility of maybe house visit for the elderly patients, or the house vaccination for the pediatric patients, and to basically create a different, how should I say, mode of taking care of the community. We have seen also support from the external, how should I say, institution. We have received, for example, donation of the PPEs, mineral waters, face mask, tent, and beds from different organizations. We are working with the different international and accredited institutions to see how they can help us, to increase again our PPE. We have submitted some grants. We are waiting to see what the result is going to be. Here again, as you can see, some of our advertisement for the teleconsultation. One of them shows one of our nurses, and the other one is one of our doctors. The other one, this is the ad that we put in the newspaper that it shows we have 15 clinics that you can call and basically get to a teleconsultation. This one basically shows again, how do we deliver the medication for free to your house? What step do you need to take? It basically shows the advertisement for the mobile laboratory services. Now, what is our growth strategy? Even during this time, we need to have a growth strategy. As we said, telemedicine is one of them with the 15 specialties. Mobile lab and pharmacy, I talked about it. Innovation and milestone, we talk about the ventilator, transporter for COVID-19 patients. One of the things that we were trying to do to increase the safety of the employees was here, use the UV lights, and there are some of them for disinfections. We tried to buy that one from America, and the response was, we do not sell to Africa. It's okay, no problem. We will make our own. And I will show you, we have basically done 3 prototypes, and the 3rd one is ready. And we have already put applications to patent it. And we are doing a research regarding the efficacy of these ultraviolet lights. And once we know it is successful and it works, then we will try to find a manufacturer to manufacture it here and then share it with the community. The other thing that we have been looking at is a intensive care unit, EICU model. We have already basically launched it. We have tested, it works. I have to thank my ICT, biomedical engineering and engineering. And our intent here is to use those capabilities for our sister institution like Mombasa and Kisumu. If they have patients in critical care that they might need help from us, we can communicate with them, because we do have a board certified intensivist here and 14 basically physicians around the clock in intensive care unit. And recently we received a request from one of the county government to help them to launch their ICU, and we are helping them. And this might be also another opportunity for us remotely to support them. And we talked about the hand sanitizer that our pharmacy is doing. And here are the pictures of some of the prototype that we did for the ultraviolet lights. The first one, you know what, not sophisticated. The second one better, but the third one is as good as what I have seen that you can buy from the United States. This is another way for transporting the patients from one unit to another unit to have a cover there to make sure the probability of cross-contamination is less. Basically a sample of the hand sanitizer that we have done here. But then takeaways from the COVID-19 pandemic. I'm very proud to say here, when I look at it and I look at my colleague, we look at the human intellect. You know what, there are a lot of intelligent people that they work in an organization, and once in a while we need to reach out and really motivate them to contribute. Untapped staff innovation potential, like the things that you saw here from our engineering department. That capability exists there, but maybe somebody didn't challenge them. And this challenging situation has allowed us, some of the employees, to blossom and see, you know what, you have a lot of capable people. How do you basically tap to that capability? But the other thing is the value and importance of each individual, how each individual can contribute. And what I tell always my colleague, I believe in the collective intelligence of the organization. If you get people to collaborate, to communicate, there is a lot that you can accomplish. And there are 3,000 people here. This is an unbelievable potential for creativity. The value of collaborations, responders, teamwork. You know what? It doesn't matter how great your idea is. If people, they do not work as a team, at the end of the day, you will not be successful. And one of the comments that I make to my colleagues, I'm not looking for one star. I'm looking for people that they can work on a team. And I give them this analogy. If I have a basketball team and one guy, you know, scores 50 points, but at the end of the day, the team loses, I have one star and the team that hasn't been successful. Therefore, we talk to people. You can be a star, but you need to be a team player. And then gaining knowledge, new knowledge on pandemic management. One of the things that we have done, we have gathered every single innovation and the document here, and we have created a repository here with the hope when the pandemic is done, we can go back and look at it and say, what lesson did we learn? What can we publish here? And how can we be prepared for another situation that we cannot predict at that time? And then we believe in every crisis, there is opportunity. And the opportunity that exists here is about future research and also creativity. And then I think everything said and done is renewed belief in equality and the sanctity of human life. And why do I say that? We got a lot of requests from different organizations if Aga Khan can be exclusive provider of care for that organization. I received it from embassy, I received it from UN, I received it from the private organization, and some of them even they wanted to pay us to reserve beds for them, sign a memorandum of understanding. And my answer to them was very clear. I know I can make a lot of money. If I agree to give you 20 beds, you pay me for it, and even if there is no patients on it. But it's against our core principle. Every life is precious. We are an institution for Kenya and Sub-Saharan Africa, and I will not basically agree to provide that privilege for one organization, regardless of how much you're going to pay me. And we have to be true to our core principle. And I think at the end of the day, when we send a consistent message to everybody, everybody came back and appreciated what we stand for. And that's really what I learned. And that's the conclusion of my presentation. Thank you.
Thank you, Dr. Baloki. So we'll start with some questions that have come through. So the first question is, what procedures does the Aga Khan University Hospital in Nairobi have in place for hospital-acquired infections? And are particle counter tests being carried out on a regular basis to ensure the HEPA filters are in good condition?
Mm-hmm. I will tell you one thing. This is my secret, okay? One of the things that you don't know, I'm actually an engineer by training. I studied architectural civil engineering, and my master's degree is in hospital engineering from Germany. And my area of focus is design of air conditioning system for aseptic areas in a hospital. The particulate count, it is not necessary. You can do that one for a benchmarking. However, if you are basically involved in the activities that might disturb a normal airflow in the hospital, you basically bring a Braunschweig particulate counter and you count basically the number of the particulate, but the number of the particulate is not important. What is important, how many colony forming units you have per cubic meter of air. And then you culture that. And then during the activities, then you go and do more basically air sampling to see if there is any increase in the particulate. Now, one of the things that we were able to do here, we were able to modify our air conditioning system and put the entire ICU under the negative pressure. We do have a HEPA filter on our systems. We do have the ultraviolet lights. And we have taken all those precautions to look at the pressure differential between the areas of the hospital that there is no cross-contamination.
Thank you. The next question is, to what extent is the COVID-19 virus airborne? And if so, are the ventilator systems protected against this?
You know what? Interesting questions. One of the problem with the COVID virus is you need to look at the size of the COVID virus. If I don't make a mistake, and somebody can correct me, the size of the COVID virus is less than 5 microns. A HEPA filter at 99.9% is efficient when it comes to the viruses and the elements that they are at 5 microns or bigger. Anything that is less than 5 microns, when you look at it from the air conditioning point of view, they basically become suspended in the air and they do not basically settle on the floor. Therefore, there is a lot of contradictory literature right now. There was a study that came from Singapore that, you know what, air conditioning can become basically one of the mode of cross-contamination. There was an article that came from Canada that they were basically also claiming the same thing. This is not a clear answer. However, if your air conditioning system has been designed properly, that you do have a HEPA filter, and before you get to your HEPA filter, you have ultraviolet lights, the probability of the cross-contamination or being airborne is much lower. And then there are also guidelines from CDC. How do you deal, for example, with the TB patients? Can you use those guidelines for COVID? At this time, honestly, I don't know. You might be able to do it, but that has a huge impact on the number of the air exchange and, you know, pressure differential and other things that you can do.
Thank you. The next question is, the response by the Aga Khan University Hospital in Nairobi is so very impressive. Could you give us an idea of the rates of infection of COVID-19 in Kenya and particularly in Nairobi?
You know what, in Kenya right now, there was 15,000 tests that was done. The positive cases, they have been around 800. I have to give the government of Kenya a lot of credit. They acted really fast by actually shutting down all the international flights, you know, creating curfew and not allowing people to travel between the counties. We have not seen the same typical, basically, behavior of the community spread, the way that we experience, for example, in Europe or in North America. However, because the capability of doing testing is limited, it is very difficult for me to tell you what is the real number of the cases. But there is a very interesting comparison that was done. And that comparison was based on the distribution of the population based on the age between Kenya and Italy. And it was really very interesting. For example, when you look at the distribution of the population in Italy versus Kenya, the people that they are in their 80s, in Italy was maybe around 4 or 5 million. And they had a mortality rate of 14%. But that segment of population in Kenya is very low. Is that one a factor that we have not experienced the same, or should I say, typical behavior of the COVID curve regarding doubling the cases? I don't know. And then there are discussions here that, yes, you might see the surge of the COVID in Kenya, maybe in September. I hope it doesn't happen, but that's the only answer I can give you. Anything else is a pure speculation.
Thank you. So the next question is, are we meeting or exceeding standards such as CDC or World Health Organization standards? And if so, in what areas?
You know what? Honestly, I can tell you in some areas we do exceed them. As you know, AKU Nairobi is the Joint Commission accredited institution. Our laboratory, for example, is accredited by the American College of Pathologists. Today, I gave another assignment to the director of the quality. The World Health Organization has a checklist how the hospitals are prepared for the COVID. I told them to take that one and do another assessment of our preparedness and then compare it with our disaster management manual, which is Hospital Incident Command Center that is being used actually by the federal government in the United States and the state of California for this type of the situations. Now, I'm sure when they bring that checklist to me, either we are over-prepared, we are prepared, or we will identify some areas for improvement. As I mentioned to you, when we decided to do our disaster management exercise, and for the surge of the patient, one of the scenarios that we played with, we're going to receive 30 COVID positive patients within 1 hour. How are we going to manage them? And during that time, we extended an invitation to US Embassy, to the British Army, to UN, and some of the insurance companies. As we were going through this exercise, their physicians were here. They evaluated our responses to this situation. After that, we have a very formal evaluation process. We went through the evaluation process and we identified few areas that needs to be improved. And we have already taken, for example, actions to correct them. One of them was about the testing, because we were doing all of them inside the ED in the negative pressure room. We decided to manufacture some booth that they are outside and it isolates the physicians from the potential patients. And once we believe we have taken care of all the corrective actions, we will repeat our exercise and see if we can find other areas that we can improve.
Thank you. The next question is, can you speculate about how COVID-19 will impact Kenya more widely, especially given the levels of poverty and those living in close quarters in some areas?
That is really a very, very good question. I cannot speculate, but I can tell you, I did have some discussion with some of the colleagues from the Ministry of Health. And I told them one of my biggest concerns is the areas that they do not have adequate sanitation and not adequate facility. Now, I have that one also in the back of my mind. One of the discussion that I had with our vice president or with the director of HR and my colleague was, listen, I'm not worried about, please don't misunderstand me, like the faculty, the physicians, the nurses. My worry is about my housekeepers, engineering staff, porters. Subsequent to that, I told the HR to actually interview and send a questionnaire out to this level of the staff and develop a risk profile and tell me, based on the living conditions of the staff in these categories, who is at the highest risk. Then once we had the result of the survey, we sat down with our infectious disease department, we looked at it, and we identified there are 351 employees that they are vulnerable, and they can become a source of the cross-contaminations because of the living conditions there. We have already made a provision. When the time comes, we can accommodate them on the ground of the hospital and basically eliminate that probability. This is a major concern, not only at my part, also even at the part of the government. But how you resolve it, it becomes a matter of the policy. I can give my opinion to the colleague in the Ministry of Health, but I'm not in the position basically to provide the resources that might be needed.
Thank you. The next question is, how do you see clearing or sterilizing the air by UV light in the different wards in the hospital?
You know what, the UV light is not for sterilizing basically the air. You know what, you cannot sterilize the air. The UV light that we are using is, for example, if I had a COVID patient in one room, you can use that one basically for, first you do your normal sterilization, and then you can use the UV light for an additional, basically precautionary method. Now, one of the things that we are doing, our infectious disease department and our director of the central supply and biomedical engineering, we are developing a protocol for testing the UV lights. But one of the things that people, they have to understand, if you look at the typical UV lights, there is a curve. And when you look at that curve, there is a correlation between efficacy of the UV lights and also hours of operations. As you operate them longer, you know what, they become less effective. And there are different ways that you can calculate what is the optimum, life expectancy of the lights and when you need to replace it.
Thank you. The next question is, does the hospital have visual negative and positive indicators?
What do you mean by that? Are you talking about, for example, if you are talking, okay,
pressure indicators.
For the pressure, yes, there are two ways you can do. You know what? We have a negative pressure rooms, and all the negative pressure rooms, they do have an alarm on it, okay? And if the pressure differential changes, then basically the alarm sounds. But on the top of that, there are again a specific requirement from the CDC. How do you test the room to make sure that it is under negative pressure? You can do a smoke test. And when you do the smoke test, it visualizes the airflow pattern from one area to another area. If, for example, you put the smoke test in a hallway and you open the door to your negative pressure room, even if it doesn't have alarm, then you see the smoke is going to the room, then you realize that this room is under negative pressure.
Thank you. The next question says, the Aga Khan University Hospital, Nairobi, like other healthcare facilities, has had to curtail elective surgeries. At the same time, many patients may have chosen to avoid coming to the hospital for routine care. What arrangements is the hospital undertaking to plan for and resume such surgical procedures, especially in the areas of cardiology and oncology care?
Thank you. Absolutely a great questions. Right before I came to this meeting, I was on a phone with one of the colleagues in the Ministry of Health. We received very specific instruction from the Ministry of Health that all the elective surgeries has to be stopped in order to create basically capacity for the possible surge. And today when I had a conversation with our colleague, the comment was, listen, at this time, the COVID is the reality, and we need to live with it and we need to manage it. In a discussion that I had with Ministry of Health, and I just dictated a letter to them, we have decided that we will test every patient that comes to the hospital for elective surgery or any patient that has to be admitted, let's say for chronic conditions. An advantage of this approach is by the time the result of the test is there, two things is going to happen. Either the patient is negative, and then we will handle them like business as usual, or the patient is positive and we take proper conditions. And one of the calculations that I did, if I have a patient that it comes, let's say, for a surgery, and you realize that there are 4 or 5 colleagues in the operating room, and each one has to be in a full, basically, PPE. When I did a quick calculation, how much does it cost me? The cost of putting 5 people in a full PPE was more than offering a free test for COVID. Then even from the business point of view, it makes sense to offer it for free. It gives also employees a peace of mind. And also it allows you to manage patients better in case, they are positive.
Thank you. The next question. Uganda doesn't have a hospital like the Aga Khan University Hospital in Nairobi. Could you comment on how they are responding?
Actually, we have had, are we talking about the Uganda as a country, or are we talking about in Uganda regarding the, basically the community, the Jamaat? There are two, if somebody can elaborate, I will be more than happy to. The country, do you know what? Unfortunately, the country does not have the same capability that we see in Nairobi, because many of our colleagues, or they might be familiar that we are building a university hospital in Uganda, which is being designed based on the North American standards. And I have a privilege to lead that project. And when we were doing our due diligence, and I spent 1 week in Uganda, and I went and I looked at the infrastructure. Unfortunately, the infrastructure in Uganda is very poor. And the biggest or the best private hospital, I think they have maybe 11 beds and maybe 11, ventilators. And that is going to create a challenge for the government. I hope, they are not going to get to the situation that they will have a huge surge.
Thank you. So the very last question that we'll be able to take for this webinar is, you used to live and work in the United States. Can you comment on their response or the response in other countries around the world?
You know what? Yeah, I traveled basically between East Africa and United States. I'm sorry to say so, but in the United States, honestly, I believe the preparation hasn't been sufficient. And I'm not saying this one for anybody to misunderstand us. I think we are more prepared here than some of the university hospital that I know. I used to work for University of California in San Diego, and still I have a relationship with them. In some of the discussion that I have had with my colleague, they do not have sufficient personal protective equipment. There is a shortage of N95 masks, okay? Here, I have 200,000 N95 masks available because we started preparing in January. I knew this is going to come. And the other challenge that we see also in the United States is, lack of the number of the ventilators, and many hospitals that they are actually contemplating for bankruptcy. I used to work also for Tenet Corporation. I have some colleagues that they had a private hospital, one of them that I know very well, and he has basically filed the bankruptcy for 2 of his hospitals. Unfortunately, in the US, there hasn't been a proper coordination, and there is a lot of, how should I say, lack of preparedness.
Thank you very much. So that brings us to the end of the session. Did you want to offer any final last words?
You know what? I do not know the composition of the colleagues or the people that they are on this call. But one of my philosophy is there is always room for improvement. If anybody has an idea how we can manage this situation, and they want to share their experience and idea with us, we will welcome that one. We are not perfect. We do not claim to be perfect. There is always room for improvement. And I want to thank basically the people that they participated for their interest to understand what AKU is all about and what we are trying to do to make a difference in the countries that they might be resource constrained, and how they can help this institution to fulfill its mission, because believe me, it's making a lot of impact in this part of the world. In the developed world, there are a lot of resources available. Some of the things that we are doing here, for example, complying with Joint Commission accreditation, complying with the College of American Pathologists, we were actually ready to get 2 more accreditation from Joint Commission, which was supposed to happen in June and July. One of them was to become a chest pain center by July, and the other one was to become a stroke center by December. But we were notified by Joint Commission that they have stopped sending the surveyor here. We are not obligated to do that, but we believe it's the right thing to do, because every human being deserves quality care. That's really my last comment.
Well, thank you very much, Dr. Baloki, for sharing everything you did with us. And thank you to everyone who's joined us from all around the world. We look forward to seeing you at our next Connecting AKU webinar. Good night.
Thank you. Thank you very much. Good night.